Journal of Cardiovascular Nursing Journal Club. I will be your moderator today. My name is Glenys Hamilton, affiliated for many years with the University of Oslo and the affiliated hospitals as a lecturer, researcher, consultant, and doctoral advisor. I'm also an external faculty nurse scientist at the Massachusetts General Hospital in Boston, USA. I'm pleased to be joined today, by Diane Carroll, long-term colleague and nurse researcher. And Diane, along with Felicity Astin and Alison Malecki-Ketchell, conducted the review that we're going to be talking about today. And the title of their paper is Non-pharmacological Interventions to Reduce Psychological Distress in Patients Undergoing Diagnostic Cardiac Catheterization, a Rapid Review. This paper was published in the European Journal of Cardiovascular Nursing in February 2017. This is going to be a really interesting exploration, I think, Diane. And it's an important topic for nurses, allied professionals, and patients. So Diane, welcome. Please introduce yourself and tell us a little bit about your background.
Well, thank you, Glenys. As Glenys has shared, my name is Diane Carroll, and I am a nurse scientist in the Munn Center for Nursing Research in the Institute for Patient Care at Mass General Hospital in Boston. I've completed a number of studies over the years in the Cath lab with the staff on a variety of interventions, both for the patients and their families during their experience in the Cath lab. Felicity and Allison and I became colleagues through our work on the education committee of the Council for Cardiovascular Nursing and Health Professions. And this led us to multiple conversations about what nurses do in general for cardiovascular patients, but very specifically, we were really interested in patients having diagnostic cardiac catheterization. This collaboration withstood time, let me say that, and with very fast and slow periods finally coming to a completion of this review that was published in February.
Thank you, Diane. So to get started, I'd like you to continue by asking you to give us an introduction to your paper and a little bit about the methods that were used.
So the objective of the rapid review was to assess the efficacy of non-pharmacologic interventions on the psychological distress of patients undergoing diagnostic cardiac catheterization. With the assistance of research librarians both in the UK and the United States, we began to sift through 2,030 citations that started in 1981 and went through to 2014. We used 3 databases and reviewed citations first by assessing the appropriateness of the sample, whether there were any interventions used, and then by the outcome of psychological distress. We reviewed the full text of 77 articles and were able to remove 48 of those articles. They did not meet the review criteria. And most of the articles excluded were due to the use of mixed samples, both diagnostic cardiac catheterization, but also having patients having percutaneous coronary intervention and electrophysiology studies as part of the sample. So that actually assisted us in removing a number of the articles in the final 77 reviews. We chose to label this as a rapid review because we used the only 3 databases. We weren't comprehensive, and we did not register with Prospero. We used the Downs and Black checklist from the Journal of Epidemiology and Community Health that was written in 1998. We used this to evaluate the methodologic qualities of the diverse studies designs in the 29 articles that remained in the final review. We chose this checklist because it was appropriate for both randomized as well as non-randomized studies. Specifically, the Downs and Black checklists assess reporting external and internal validity and power. There are 27 items in the checklist, 10 items reporting on the assessment about whether the information in the article allowed the reader to make an unbiased assessment of findings. There were 3 items for external validity that addressed generalizability, 13 items for internal validity that assessed bias of measurement and subject selection, and then there was 1 item that we used for assessment of power. Each of the 29 articles were assessed and scored by 2 researchers, which was either Felicity and myself or Allison. And then we met via Skype to reach consensus on the scoring of all of the 29 articles. Studies were grouped by intervention. There were 3 categories: procedural education with 12 articles, psychological preparation that included 4 studies, and then the relaxation techniques that reviewed 13. And these techniques included both relaxation, massage, and music. Using the Downs and Black checklists, we found that the smaller sample size in most of the studies and the lack of a comprehensive reporting hampered the ability to generate a high score on most of these studies. The power assessment score of 18 of the studies was less than 3, indicating the inability totally to assess whether negative findings from a study could be used due to chance alone.
Okay, thanks, Diane. It's interesting, this rapid review is a new, it's a sort of relatively new anyway, but you've given us insight into the way you designed the review. And explains what your article's about. And we have had a lot of questions in. I think this is really good that we've had a lot of interesting questions in. So first I'll read the one from Trond Røe Pettersen. He's a clinical nurse specialist and a PhD student at the Haukeland University Hospital in Bergen in Norway. And he says, as the focus of this review is on anxiety and depression as markers of emotional status, why was depression not included in the search terms, Diane?
So we used the criteria of the sample meeting inclusion criteria of a diagnostic cardiac catheterization. And that's the subjects that we're really interested in. And then the second level was looking at non-pharmacologic interventions to assess in the citation. So we really were looking predominantly at making sure our sample was indeed the subjects that we wanted. We also were very interested in only looking at non-pharmacologic interventions. We did have 3 studies that in the review that measured only depression, and they were included, though this really was not listed as a search term. It was obviously overlooked, but we believe that we included all the studies that did measure depression. So even though it was not listed in the original search terms, I think that we felt very confident that we have all of the studies that measure depression in this particular patient population.
Okay, thank you. And I hope, Trond, that if you're watching, that that's a good explanation for you. I think it's clear and explains the process. Now a question will jump from Norway to Sweden. And I have several questions from Axel Wolf, PhD, at the Sahlgrenska University Hospital, where he's a senior lecturer and a certified nurse anesthetist in Sweden. And his first comment is, I would like to suggest an idea of a research study that uses virtual reality and mobile technology to provide the patient with both sound and video. The technology is already available and cheap and could be used to tailor the user experience toward the preference of the patient. Combining this approach into a patient-centered care concept could be quite interesting, combining knowledge sharing as well as an intraoperative user experience that's tailored to the patient. So what do you think about that, Diane?
Well, I agree. As technology changes, there are more opportunities to improve the alternatives for patient education. And based on patient preferences would be the best way to do that. There have been, in the review, there were 2 most recent studies, one in 2012 and 2014, that actually used a DVD and a multimedia approach to patient education. I have to just say that having done a study with a DVD for patients having percutaneous coronary intervention, the need to photograph the content and add verbal text was a challenge with a limited budget. We luckily had a professional photographer married to one of our investigators, and we had staff that were willing to be the actors in our pictures, as well as a staff nurse in the Cath lab who was actually a professional actress, so that her ability to do the overlay of the voice was really helpful. Without all of that having been given to us gratis, we would never have been able to complete the video because of the expense incurred by just having professionals do that. There were subjects who didn't really want to participate in that study, and as they were not interested in knowing anymore, the blunderers who make it through all of this with minimal information, that was the patient choosing his preference for information.
Okay, thank you, Diane. Yes, times are changing. Mm-hmm. Research will reflect this. Axel also has another comment. He says, I think that it would be of interest to discuss patient involvement in these kind of interventions, and also suggest that the future research direction maybe shouldn't be to find the possible efficiency of one versus the other intervention, as suggested during the part regarding massage, etc. Instead, I would like to argue that patient choice, preference, and resources may very well be used to co-create and tailor non-pharmacological interventions that suit each patient's preference and needs. So would you comment on this second part?
Sure, I couldn't agree more with you, but the time and the costs associated with, especially the relaxation interventions, cause one to pause on how to provide all of these interventions in a cost-containing environment. In the United States, it is an interest in offering all these alternative therapies to patients in a variety of different settings within the institution, because patients are asking for them, but how to pay for them is the burning question. Oh. Certainly in the oncology world, we actually have an alternative program that offers a variety of different options for the patients, but the patients are having to pay out of pocket for those. So that, again, we get back to the cost of all of the potential wonderful interventions we could be doing, and how will we pay for those? Sorry.
Which is a big problem for everybody, yeah, I think,
it's the really.
Money. And a last comment from Axel, I see, about countries and age of the articles. He says, to my understanding, the majority of articles are from the US, and also the majority are quite old. How does this impact the possible implication for this kind of intervention in Europe?
I would agree that most of the articles were from the United States, but there were 9 other countries that were represented in the review from across the globe. The countries of origin may reflect the status of nursing research in the early 1980s, 1990s, and with people, nurses becoming more involved in research, I saw an expansion beyond the United States. And the most recent studies really are from quite a diverse group of countries, and the Asian countries being well represented too.
Yeah. Okay, good. Now we'll go a little further south to Italy. Some questions from Edita Litulip. She's a PhD student from Italy. She states, your comprehensive review includes dates from studies performed as long as 30 years ago. During past decades, the technology of cardiac catheterization has markedly improved. Do you think that the value of the evaluation of psychological distress during cardiac catheterization is still necessary these days?
Well, although I would agree that the efficacy and safety of diagnostic cardiac catheterization has changed. I can remember early in my career where you would greet the patient and say, we'll see you at the end of the day, because that's how long it used to take, to now they're gone for an hour. So the shortened length of stay, the fact that patients with diagnostic caths still are going home as soon as their procedures are finished. I still think the experience of a cardiac catheterization still lends itself to being giving subjects some psychological distress, basically because of what the potential results mean to the subject, as well as the impact or the implications of what those results are. Again, being awake during the procedure, which patients are, as well as the potential identification, as I said, of disease, really lends itself to causing some people to pause and be concerned about what these results might mean. Even the most recent studies that we looked at during the late 2000s and during the 2000 teens did still show that patients did have suffered some psychological distress with the experience of diagnostic catheterization.
Okay, Edita also says, I'd like to ask your opinion, Diane. Which tools would be the most appropriate for the evaluation of psychological distress?
Well, as you can see from this review, most of the studies did use the Spielberg State Trait Anxiety, and I think it's an appropriate scale for measurement of anxiety. 20 of the studies use this scale, which all allow the comparison or the ability to compare the different interventions across each of them, because everyone measured anxiety the same way, which I think was very helpful. There is also the Hospital Anxiety and Depression Scale, which is currently, it seems to be being used more frequently, though it was not in any of these studies, but I've seen them more recently in the literature as a way to comprehensively manage both manage and measure anxiety and depression.
Okay, and I think she had another question about scales. Yes, she said in a few studies that the visual pain scale was used for the evaluation of pain. Do you think that it's reasonable to use other tools or scales for pain evaluation? It would be interesting to evaluate the expected pain and stress of patients before procedure and compare it with unpleasant feelings during the procedure. Are the patient's expectations of pain and stress reasonable, she says, keeping in mind that patients were provided all information about cardiac catheterization and they've signed informed consent before the procedure?
I think visual analog scales currently, at least within the United States, are considered the gold standard for the measurement of the perception of subjective pain. So I think that was an appropriate measure, though we did only have pain measured in 3 studies. And as you can see from the results, it's not something that was of predominant interest to people. The pre and post measurement is certainly the better study design for the evaluation of psychological distress. The collection of data actually during the procedure, I think, may be very difficult to do. Plus, this potentially, and I'm not sure of the European experience with this, but in the United States, we predominantly sedate patients, though not totally, they're still awake, but they are sedated. So that would impact on the accuracy of their response. I believe the environment of the cath lab and the signing of an informed consent would increase anxiety. Certainly, we observed that where subjects or patients would arrive and be very nervous about being in a very alien environment. So I would agree, but I don't have any research to say that doing informed consent would confirm that belief.
Okay, I think that's true. You know, we don't really have a lot of research in that area, and I think this whole session will point out the lack of research that we need. But she also asked, let me just put this in, what do you think about stress level during other investigational tests, such as cardiac MRI or CT?
Well, I believe, and I would be one person who would be very anxious that both MRI and CTs have the added concern about claustrophobia. And here in our hospital, all patients are actually asked before they actually have either one of those tests done how concerned they are about being claustrophobic during that experience. I'd assume this would make the patient more anxious. It certainly makes me anxious to just even thinking about it. So I would say I'm really not, I would say yes, they're more anxious because I am just thinking about it. But I also don't know the literature to say with any definitive answer that having a CT or an MRI would be more anxiety provoking.
So I hope that's hopeful, Edita. And we're going to I see another question in from Norway. Irene Valaka in Norway is a PhD student at the Western Norway University of Applied Sciences. Now, she states that the researcher wanted to find an effective approach to reduce psychological distress, but the findings in the abstract do not suggest which non-pharmacologic interventions were able to reduce psychological distress. What do the researchers suggest after doing the review?
Well, after the review, we recommend, and I think it's pretty standard, that procedural education is a very viable intervention. In our review, 11 of the 12 studies demonstrated reductions in anxiety. In the one study that did not use a non-standardized assessment. There were very mixed results with the psychological preparation, and it reflects the small samples and the diversity of the options that they used within all of those studies. And in relaxation techniques, we had larger samples, but there was not clarity within those results about which would be the more positive results for these interventions. And you do have to look at the experience of having the work done the day before versus what actual reality is in finding subjects to be able to train them, for example, for relaxation techniques. And people having massage is another time-consuming portion before a diagnostic cath.
Yeah, that's certainly true. She also states, Diane, it's unclear why you used procedural-related pain as an eligibility criterion. The variable being investigated should perhaps be clearly identified and presented in the background for the study. Can you explain that for her?
We didn't actually use it as an eligibility criteria. It was actually an outcome criteria. And the only reason we reported it was that in a couple of studies, they did talk about pain. And it was on only 3 of the relaxation studies. They measured, a measurement of pain was very low, and the relaxation techniques didn't have any effect. I think it was just an added serendipitous find that we commented on.
Oh, okay. And she also says, could the population and clinical pathways have been further limited? Participants were to be over 18 years, undergoing elective diagnostic cardiac catheterization.
We limited the inclusion criteria so that studies only included this specific population. And as we talked earlier, the number of studies that were removed from the rapid review a lot of them were due to the fact that they were mixed populations. They included patients with percutaneous coronary interventions, as well as there was one study that actually included electrophysiology patients. So in order to make it as clean as possible, that was the reason we did that.
And now we have a question in from your colleague, Felicity Aston, and also one of the co-authors. She's at the University of Huddersfield. And she says, what non-pharmacological approach to reduce psychological distress in this patient group would be the most appropriate to implement in practice?
And the key point that I think Felicity is making in her question is the implementation in practice. And I think we have to agree that procedural education, be it either through a printed word, a verbal discussion, or a multimedia or a virtual reality approach, all of those would be the most appropriate from an analysis perspective on getting patients feeling less anxious or depressed. And the whole issue of finding the appropriate time to do this has always been an issue also, because here in the United States, patients come in 2 hours beforehand. So we're dependent on referring physicians as well as the written word to be able to prepare patients for this type of procedure.
All right. So Felicity, I hope
I hope you agree with me, Felicity.
Okay, that's true. May I have a question?
Yep.
Okay. Because I just, what are the potential pitfalls in conducting research in the cath lab? Can you give us some examples?
Oh, can I give you an example? I've done 4 studies in the Cath lab, and each study offered a very unique challenge. But I have to say the one that provided the most challenge was doing a back massage study. And that was one of the studies that was reviewed in this review by McNamara. I was the senior author here. The 3 authors on this paper and myself were all invited in. They were all 3 staff nurses. One was from the coronary care unit, one from our step-down unit, actually one worked in the Cath lab. So they were also had on their own been trained as massage therapists. So we were tasked with collecting study data, and we included in that study the measurement of heart rate variability without impinging on this Cath lab schedule, because the issue of not impacting on the flow was of paramount importance. So we collected the data for the study, the patient over an hour. So we asked our subjects by calling them the day before if they'd be willing to come in an hour early. Boston has significant traffic issues, and we thought it was actually a good idea for them because it was coming in like at 6 instead of 7. But a lot of the people that we called that were having diagnostic caths or PCIs, diagnostic caths, were really not interested in driving in an hour early. So we lost a lot of subjects because of that. But when we got the subjects in to the hospital, we then had to collect our data for 20 minutes, the heart rate variability data for 20 minutes before. We had to then give them a 20-minute back massage, and then we had to collect data for 20 minutes after. So that was a challenge because patients arrived late or their scheduled procedure was moved up, as well as those patients who actually didn't want to take advantage of us telling them to come early was a better way to come into Boston. So, it was with the assistance of the investigators who all knew the interventionalists fairly well, who also had done a lot of study data collection for them, that we were able to get them to assist us in the protocol and support us as colleagues in doing research in that environment. We hired a massage therapist who was from Ireland to do the massage for us. She had never been in an acute care hospital in the United States, and she had never been in a Cath lab. So she was like a deer in the headlights when we initially invited her in. So she was incredibly nervous. And I'm like, well, this isn't going to work really well at us helping to do a massage to help people relax. So the strategy that we used, which was one of the best things I've ever done, was to have the massage therapist come in. And in order to reduce her anxiety, we piloted her doing the back massage in the environment with 3 of the staff. And I have to say it was the best thing we ever did, because the staff then were like, oh, we can sell this. This is fabulous. Why would anybody not want to do this? This is great, wonderful. And it was a great successful strategy in gaining the support from the staff to be able to do this in this environment. It took a lot of effort, a lot of massaging in the verbal way of getting the staff as well as patients to agree to it. We had one woman who had never had a back massage, and there were a number of subjects in that study who had never had a back massage, who rolled back over after hers and said, I don't even need to be sedated. I am all ready. Let's just get this done. So there was, there's a lot of give and take. It's really hard to maintain the fidelity of an intervention in an environment that's very busy, very chaotic. We luckily had 2 recovery areas, one for before the procedure and one for after. And what we were doing was doing patients that were the first cases of the day so that we could have a quiet environment that we were able to do the back massage in. Otherwise, I'm not sure that it would have worked throughout the day because there's just not enough bed space. But we worked it all out. It was a successful study. We had a lot of fun actually doing it. But there's a lot of issues around being true to the intervention in an environment that's very busy.
Thank you. I hope that's really helpful for people who might be thinking about doing research in the cath lab. It sounds as if carrying out this research can be really challenging. Mm-hmm. The setting's sometimes very busy, as you say. You need acceptance by the staff, the timing of getting everything done without upsetting the patient, and ultimately sort of managing the patient while conducting research.
And managing the staff that are helping you do the research.
Right.
Very challenging.
Oh, well, we've had a lot of questions, but I think it was really good. We really wanted to include them because that's what this is all about, I think, a journal club. But unfortunately, we're coming to the end of our time. So let me sort of wrap this up. As Diane has so clearly pointed out, these studies show promise and encourage us to pursue research on interventions to reduce psychological distress for patients undergoing elective diagnostic cardiac catheterization. And future research can benefit from the early studies in this area. Knowledge is expanding and research will emerge with interventions that work best for each patient. The authors did a great job, I think, in synthesizing the evidence up to 2014 and point the way for further research on this topic. We acknowledge there are huge gaps. The quality of the articles is problematic and indicate that more rigorous studies are needed. So a big thank you to the people who sent in questions. We do need to test ways to make the patient's experience better when undergoing any potentially stressful intervention. We're now in 2017 and more options are emerging in patient education to reduce this distress. Whether procedural information, psychological preparation, or relaxation techniques, or the use of technological interventions with an app, or virtual reality where you project a virtual world and surround the patient in it. It's an immersive technology where the person actually thinks they're in some other environment. In this instance would be the cath lab. I'm sure there's other technology developed or in the pipeline, and it's an exciting time to be doing nursing research. But we do need to move forward and embed really, I think, research, on patients' needs and wants into practice when we have good evidence. So thank you, Diane, for sharing your ideas today on this important topic. And publishing, I would say, in the European Journal of Cardiovascular Nursing is an excellent choice to disseminate findings. Access to this and other superb articles can be found by going to http://journals.sagepub.com/home/CNU. So for anybody who doesn't have that, http://journals.sagepub, all one word, .com/home/CNU. If anyone has questions about the session or the paper, please email EJCN Club, the EJCN Club at sagepub, all one word, .com. Thank you so much, visitors, for spending time with us today. You enjoyed it, Diane?
Yeah, it was fun.
It's just good to share this and to disseminate fruited findings leading up to looking toward past findings to look towards the future. Thank you so much.
Thank you.